Juan Valdivia, who will tell us from the deep of his heart, in a very simple word, what we are doing with the most prominent problems which stay behind of us in freediving.
Thank you, man. Okay. Thanks, everyone, and welcome again. My lecture is going to be, I hope it's relatable to you. I started freediving in late 2014, barely, and sort of I entered more like the medical part, scientific part, mostly clinical part of freediving, or the side door, this door that we all come through freediving, curiosity and experience. So I'm going to tell you the observations we've made with Dr. Melkov in regards to the alteration of the mental status in freediving. My disclosures is this is not AIDA material, educational material, or official statement, and I have no financial relationships. I'm going to present to you some cases, real life cases of DCI and blackouts, and I will ask you not to film anything because it's sensitive. I have permission only to show you here. I want to dedicate this to Carla. He's the reason why I'm here and everybody's here, or a lot of people are here. She's the past president of AIDA. And we actually introduced in 2018 even a mini neuro exam from freedivers to diagnose DCI or to catch DCI symptoms. I always like to quote William Osler, is a very famous surgeon, early 19th century. That is one of the first ones to advocate to teach medicine at the bedside of the patient instead of just going to a classroom. Teach it next to the sick human being. And he advocated the hospital as a college. And I feel like if you want to learn freediving medicine, you have to be connected to freediving. You have to be in the water, and you have to be next to you guys. And I feel like in medicine, the old dogma is you have to listen to the patient. But in freediving medicine, you have to listen to the athletes. Because the athletes will teach you, and then you'll confirm with the books. There's another good quote from him. The good physician treats the disease, and the great physician treats the patient who has the disease. So I feel like instead of, it's good really, giving you advice on medical issues in freediving is useless if I don't base my knowledge on smarter people than me, like Oleg, Erika, Chantel, Tino, Murat. I wanted to show you this briefly because this is we discussed earlier about what the heart does and the axis and what morphology changes happen in freediving. This is an actual fluoroscopy of my own chest and my heart at the hospital. And what I'm doing here is packing beyond total lung capacity. And what you're gonna see now is exhale to residual volume and then reverse pack below residual volume.
Wow, this is the most true video ever.
So this is what happens to you when you're going to 60, 70, 80, 90. This is way below RB. So your diaphragm gets in between your heart. So each reverse pack that you see, it's changing your morphology. So I was only able to confirm what I do with a picture of my own heart. It's a lot of X-rays on my own. So if I get cancer, I'll call you. Hopefully never. This is something we presented at UHMS, is a society for diving in general. And this is a description of what happens to us clinically from the outside to try to put names to things. When I started in 2014, just being a volunteer medic at Vertical Blue, I would ask my neurology friends, how do you call this? How do you call that? They would have no idea. And in fact, if you ask most neurologists in the US about blackouts, about SAMBA, about the spectrum of SAMBA, which we call SAMBA, they have no idea. So this is the first description of a proposed, we call it a clinical progression. You start being conscious, let's say in ascent, you start pulling. being fully aware of yourself, right? And then we discussed with Dr. Melkov about what happens afterwards. There must be some degree of asymptomatic hypoxia where your saturation starts dropping below 80, but you have no awareness of it. And there must be something called symptomatic controlled hypoxia where not every diver, but only elite divers are able to tell when something is wrong. Like if I'd ask you, when do you feel like there's hypoxia? If you're a beginner, you may say, I don't know. But if somebody has done the same dive hundreds and hundreds of times and is an elite pre-diver, they are able to tell when something's off the normal. And when I ask elite divers, when would you say that hypoxia starts? The responses I've heard are when something is slightly off the normal. Like I feel something's different. Because I've done it so many times, but when I feel something's different, that's when I know something's gonna happen. And by definition, if your awareness is impaired and you feel like you may have hypoxia, you better have a lanyard on you or you better have a safety next to you. Because if your awareness is impaired, you're in trouble already. Then you have LMC, what we call samba popular, right? So samba is not something that you just have when you're awake. There's something called conscious LMC, and I'll show you my own video. There's something called unconscious LMC. I'll show you my own video of my own samba. And when you go into unconsciousness, you go into syncope, what we call blackout. And blackout is not the same for everyone. So before one may think, well, if you have a blackout, is you dive, you dive, you dive, blackout. It's not like that. It's a progression. You start with underwater signs of hypoxia, and it ends into blackout. This is my own video of myself when I had some by Dennis Blue Hole at 70 meters. This is the same safety diver actually, and I have full recollection of the event. So you see I do hook, 1, 2, 3, 4 hooks, and then you see my samba. But I'm fully awake, alert, and I remember everything, so it's conscious. If somebody asks me, how do you know if conscious or unconscious? If I ask them if they can remember and recall the event.
So what you qualify as conscious loss of motor control,
Yeah.
are there instances where a freediver has a hypoxic episode, so for example an LMC, but recovers without assistance and is able to, for example, in a competition complete a surface protocol, but has no recollection of the samba or the LMC? Is this conscious or unconscious?
No, all right, thank you. No, I feel like if you cannot recall how you survive a dive, I don't think that's conscious. I wouldn't call it conscious. If it was a patient in a hospital, I wouldn't call it consciousness. So I wouldn't say that's a patient that is awake. Yeah. So for me, if someone cannot recall the whole event, yeah, but I'm not a judge and I'm not applying to the rules or judging.
I was just curious how you define hypoxia, because I mean this is part of the sport. Everyone will have hypoxia in the end, and also everyone has a different tolerance to hypoxia. It is said that non-divers black out somewhere around 50% saturation, and we have seen that some trained divers, they can stay sort of awake until 30%. But when you use the word hypoxia, you mean like threatening the mental functions,
Right.
or something like that. But that must also be on a different level for a trained diver. Do you think the actual level is important, or do you think how do you subjectively describe it?
Because I'm the clinical guy. I define hypoxia when I see a change in the performance. That's all I can say from the outside. I'm not measuring saturation underwater or anything like that. But if I see a change and the right setting, not at the bottom but on ascent, then I'm thinking there must be, in the usual scenario, there must be hypoxia. And
hypoxia in 60%, most people say, I am okay.
Correct.
So hypoxia is something very undefined, and I think it would be helpful to define it better.
Yes.
The reason of the introduction of this classification is not the physiological one. Of course, everybody knows that drop in the level of oxygen below some features, we could physiologically call it hypoxia. But this is a clinical interpretation, dependless of the actual level of oxygen in the blood, because all the symptoms may start in a very, very difficult, very, very different time story level of oxygen, depending of many, many factors.
Can we call it symptoms of hypoxia, perceived hypoxia? Because under 90% can also be called clinical hypoxia.
Right.
COPD patient below 90% is hypoxia.
Right.
Like symptomatic hypoxia.
Yeah, I agree.
When you cannot recall what happened, this is uncontrolled.
So,
Okay, so just a little bit about hypoxia and obviously unconsciousness, because that's what really happens. The fact is that a lot of it is also denial. So if you come up and you think that you have like done a good dive or something like that, and then what happens is you think that you've done it, but you haven't. That's also a bit of denial as well. But I agree with the Pacific. Hypoxia is probably the best one to go.
Hello, sorry. So question is, because now we have in the rules some one chapters related exactly with recognition of the blackout state and the exact beginning and the end of blackout, yeah? What is your opinion? How could we visually recognize the exact moment then blackout began and exact point then it's finished? So conscious, unconscious, yeah? Then it's unconscious state and then it's come back to the conscious. Just opinion, just some visual science that can be used.
It's a loaded question, huh? Because that overlaps into rules. And this, if someone is awake, alert, oriented in place, time, and situation, I will call that human being awake. Somebody seems awake, but he's not oriented and he's not able to respond. I wouldn't call it full consciousness.
that would be lower level of consciousness.
Yeah, correct, right. So that's very, and that will depend on the observer as well. So that will be difficult. Unfortunately, I cannot give you an answer that will impact judging. So, well, let's proceed. I'll give you my thoughts on DCI, and I know this is a very, very charged topic, very controversial. I'll give you my experience on it and my thoughts on it. And the reason why I want to bring you this is because there's been incidents in the last 5 years, and I feel like the occurrence of this in freediving is growing. My background is not primarily tech diving. I'm a scuba diver, but I haven't researched gases, but I've been in touch with the community in regards to these cases, mainly because of the symptoms. And as it happens, when when this happens and you get involved with symptoms and clinical, is based on trust. I'm bringing you my experience. So the definition, and again, Tino, please intervene, or Chantel, and everyone who wants to critique. So if you see neurological changes after a deep dive or a dive that you call it high risk, we are thinking, and it's safe to assume, is decompression rather than a stroke or anything like that, unless there's variations. If you see a deep dive, high rate of ascent versus a very shallow dive, very, very, very shallow for a beginner, and you see symptoms, you may assume it's something else. But if we're training, like we're training at the Blue Hole or anywhere else, it's safer to assume it's decompression. Now, why I'm making a case against recompression? Because it's something that it keeps coming up from multiple angles. I feel like the community is very hungry for guidance and knowledge. It's strongly discouraged by everyone. Yes, in the literature, reports there is multiple positive outcomes. However, we just still cannot control all the variables. And if you cannot control the variables, it's almost like doing surgery in the dark. That's something you don't want to do. So let me tell you the factors to consider when you're thinking about either trying to go for the easier or potentially cheaper option. Is doing recompression in DCI is very risky. There's a universal agreement that just doing surface oxygen is enough and is effective. I feel like the reason why I'm bringing this up is because the cases that have happened recently, many have used recompression to manage symptoms, but we are not sure if what they did has actually helped the symptoms. We're not sure if that has a cause and effect. We don't know if the recompression that these divers did actually healed or cured or treated anything. We just don't know. And I have to be very open with that. It's very controversial, and if anybody would even think of doing this out in the field, is only when there's not a chamber available, and I'll show you why shortly. Let's see. It's extremely high risk. So my message here is, without taking too much of your time, is there's a strong opposition against in-water recompression. If you're thinking or talking to other freedivers, there's consensus among Dan and other societies against it. Now, despite the opposition, in-water recompression is considered by the diving community, scuba community, and freediving community. But I have to say it's unfortunate because it's very high risk. There's many arguments against in-water recompression. I feel like if I want to summarize this slide in one, is you cannot control what happens underwater. And one of the main risks is loss of consciousness underwater, and oxygen toxicity and seizures. Now, let me see why the community is asking about this. It's sort of concerning how many times I've been asked what to do and how to implement in-water recompression, as if I knew that, because I don't. Our personal bests are getting deeper every year. It's a matter of fact. We all use freediving as biofeedback therapy for almost all of us. We're just not going to stop doing it, and we're going to try to get deeper every year. We are very used to having watermanship. So if in a boat, if you see sharks, all the scuba divers will come on the boat, and we will all go in the water, actually. So we feel like we're doing breath hold diving all the time, that our familiarity with risk is so high that another risk is perhaps at the same level, but this risk is way too high. So our watermanship is very high. So we're very comfortable in the water. We're very familiar with risk, and we want to be protected against DCI. However, I need to tell you how not to do it. So coincidentally, I've been treating physician for 8 cases of DCI, not treating with in-water recompression, but being called or assessed virtually or in person, 2 in person and 6 remotely. All of the cases were neurological at cerebral level, except one. I've only been present on one time where in-water recompression was done when I was called in the middle of it, and I've seen it done. It doesn't mean it works. It doesn't mean it's safe. DCI, I feel, is underreported, so I will show you shortly. And I feel like in water recompression is treatment, and treatment can harm. I can tell you from experience that what I do outside freediving is brain and spine surgery, and just as much as you can make a difference, sometimes in a patient, sometimes you can harm. And that's, in my line of work, we take 7 years to learn how to do something, and we take 17 years to learn when not to, probably longer. I make a big parallel of this with neurosurgery because it's semi-invasive, and I feel like we're doing, if it's done, it's almost like it's doing surgery 100 years ago. It has great risk of harm. I have to be very firm and say it again and again and again. Be very careful if you're thinking about doing recompression. So planning a position is everything, just like in surgery. And primo non nocere is something that we say when we graduate med school, is first do no harm. If anything I can tell you about DCI is early diagnosis, and I'm going to show you the tool that was presented to AIDA International. You have to do safety stops, maybe not safety stops underwater, but safety stops meaning when you cannot proceed with something. Let's see. I don't know what's happening with the slides. Yeah, I'm not going to show you. So, okay, this was presented to AIDA 2017, actually, after the World Championships in Roatan. So you see that neurological exam is actually, it was something that is very important. I wish that you guys will learn how to do one without having to go to school for it. Because you don't need to have the whole idea of having AIDA giving you the tools to be safer is for you to not need necessarily a medical provider to do an assessment and to have judgment and to know when to evacuate. So this was presented in 2017, and back then even we were talking about DCI. The mini neuro exam was presented to AIDA in late 2017, approved in 2018. And the reason why I want you to learn this is to have awareness on when to act. And I will show you a case, a real life case on how that's important. It seems very simple, very sensical, but it can save a life. You need to know not how to diagnose MS or Parkinson's or dementia, but you need to know when something's wrong. And without asking, you won't know. You need to know when something is new or worsening. So this is a tool that was presented to AIDA as part of one of the guidelines. And now instead of having, I remember I was asking 2015, 2016, how do we diagnose or are aware of the possible DCI? And why am I telling you this? Is because in the Americas, the two best places to do depth training are Dean's Blue Horn in the Bahamas and Dominica. And those two places do not have a chamber. If you want to go to a chamber from the Bahamas, you have to go to Miami. If you want to go to a chamber from Dominica, you have to go to Martinique. So there's no chamber. In the Bahamas, there's no ICU, no CT scan, no artificial ventilator, nothing. And we were doing training there back in the day.
Why they still do competition there? People, they're still going.
Right. So, so this was also presented at UHMS, and it's a very simple acronym, MFSCO2. Everyone can remember mouthfeel, snorkel, CO2, because it's simple. We just know that. All freedivers know that. If you follow that acronym, you can do a neuro exam in 5 minutes. You use M for motor, so you want to look at arms, face, like symmetry. You want to make sure there's symmetry when you do an examination. Why? Because when you're looking at your fellow diver in the platform, in the middle of nowhere, as in Dominica or Vertigo or Dean's Blue Hole, you want to make sure you look at them for at least 5 minutes or 15 minutes ideally. You want to know when something's new as well. You need to ask them, is this new or not? In medicine, we don't look at just snapshots of things. We look at trends over time. And we need to identify trends. Now, if you don't know what a biceps is, where a deltoid is, you don't need to know that necessarily, but you need to do pronator drift. Very simple. If you put your arms like this, and ask you to close your eyes, and you hold that for, let's say, 20 seconds. Usually, you can hold them symmetrically, but it's a good test to look at subtle weakness. You can see pronation, and it's very subtle, and the patient or the freediver may not be aware that they're pronating, but you can catch it, okay? Very, very important. Now, if you don't know how to do that, you don't remember, you can ask them to do a plank for 30 seconds to a minute. Now, all you guys are healthy, young, top shape. If you ask somebody to do a plank for 10 seconds or 30 and their one arm is giving out, then that's a very subtle sign of weakness. You can ask them to hold a squat for 10 seconds and the same, or do a push-up against the wall. Do I do this in my clinics to some patients? Yes, and I use that. M also for memory. So what's your name? What do you have for breakfast? Did you ride a car? What's your address? That's very important. F for feeling, sensation. So you want to test face and extremities, and you don't need to remember all this. It's so tedious to look at dermatomes, but all you need to have is a snorkel or a nose clip, and what you need to do is you just touch the skin on both sides, and they have to tell you it's symmetric. Arms, legs, face, trunk, okay? Pronation, supination is for F for fine motor skills, so everyone can do this and this. You should all be able to do that. I hope. And that's important because the first case of DCI that I was exposed to in late 2014 in the Blue Hole in the Bahamas, went to the medic saying, you know, I'm feeling great, but I cannot text very well, and I cannot brush my teeth really well. So you need to ask that as well. Coordination, finger to nose test and heel to toe. That's very, very important. And I show that because we all say I'm okay all the time, right? I'm okay. The surface protocol, I'm okay in freediving, is actually a mini neuro test because it tests your speech, cerebral function, motor function, coordination, orientation, sight, and understanding. And I actually use it at the hospital. I ask my patients, show me the okay sign. So finger to nose, you can do that, right? You can do that. It's very, very simple. It takes a couple seconds. Heel to toe as well. And then orientation, you have to be oriented on person, place, and time. And 2 for eyes, you know, the double vision, blurry vision, dark spots. So if you find one point in the exam that is abnormal, then you need to raise awareness, right? So if someone has an exam like that, I would say no diving for the rest of the day. And if I'm considering DCI, that means hydration, surface oxygen, evacuation. That's the gold standard.
AIDA International at the moment does not recommend in water recompression because in water recompression is dangerous procedure. And we clearly understand that sometimes risk of development of decompression sickness, or of further development of decompression sickness, is higher, probably the risk of putting freediver in the water. The question is, who will weigh this risk? In water decompression is clearly described in year 2019 in guidelines published in Diving Hyperbaric Medicine journal by Professor Simon Mitchell. It's a very well-known procedure. The issue is who is responsible for taking this decision. And the second, whether in water decompression would, like Tina said, would overcome the positive effect of breathing oxygen on the surface. So once again, we cannot recommend right now on behalf of AIDA International to use in water decompression.
Correct.
Maybe someday we will be closer to understanding of that. And this is one of the reasons why we are doing here our research. Fred, go first, you're second.
Thank you, Oleg. Just to add something, for me it's not the question of having or not in-water compression, it's just having or not an hyperbaric chamber
Right.
Yes,
for
it's not
competition.
exactly.
That's all. If you want to organize a deep competition, you should have an hyperbaric chamber.
Technically, to breathe oxygen, we need to be technical diver, by the way.
Right.
To be technical diver,
Right.
to be allowed to breathe pure oxygen
Correct.
underwater. So we can technically provide oxygen to everyone.
Stop doing the 5 minutes and 5 meters.
Yeah, exactly.
Yeah, just another point for the use of hyperbaric chamber. I agree with him because if you analyze deep accident with no limit, deep diving, concentrate on variable weight, the people who resume their symptom are taken charge very rapidly to hyperbaric chamber, less than 2 hours. People who was above 2 hours, 3 hours, or 6 hours have always symptoms. So hyperbaric chamber, but close to the hyperbaric chamber.
Sure, of course.
It's like in scuba diving.
Okay. Well, I'm glad we talked about this, huh?
Let's keep it going. We have all the week.
We're gonna cut it short, and then we're gonna discuss this in the safety. But it's very, very good topic, and I feel like we're getting to a consensus, and it's almost such a consensus that we're gonna pass it to the leadership so that they can make some changes. Do not do in water recompression. That's my message. And if you're thinking about it, you should have thought about the planning and being prepared to hydrate, surface oxygen, and get the hell out of there to a chamber. That's about it. So I'm going to finish up with a quote by someone I met at DEMA a couple years ago that for scuba diving or technical diving should be prepared for DCS. That was a long time ago. It's 20 years ago. For freediving, we should be prepared as well, but we should be prepared with the gold standard, which is chamber. Now, I'm a clinical physician. I do surgery, and I wouldn't be able to do that or be serving you guys without the smarter people in the room, like Tino, Fred, everyone else. And so that's my statement. The more I know about freediving medicine, the less I know. These are my references, and we're going to continue this in the safety. Thank you.